thank you all for coming. I think we'll have an interesting time. How I teach this has been evolving over the last 6 months, and I'm going to do it a little bit differently than how I've done. We're going to cover fewer things, like less background, a little less context, and more really focusing on how to be a clinician, and how to think like a clinician, how to evaluate someone, how to follow up someone, what kind of obstacles you can find in treatment, how do you deal with those obstacles, what you might see in a typical course, and also we'll talk about HPN in terms of specific diseases, depression, anxiety, etc. Tomorrow, we're going to do a little bit about the background on the physiology, and I'm going to do more integrated. We're going to go over the same kinds of things today, but I'm going to do it in terms of case samples and things like that, and get you guys to answer. And I think you'll learn it because it's you integrating it is the most important thing, and it'll make you a good clinician that much faster. But a little bit of context is in order. So, since HPN, high performance neurofeedback, is a form of neurofeedback, a very specific, narrow form, particular form of neurofeedback. And since neurofeedback is a form of biofeedback, we'll just start with biofeedback and work our way back to HPN. So biofeedback's been around since the 60s. And the idea with biofeedback is that we learn some physiologic control over a process that we normally have no control over. And we do that by getting feedback or information about what's happening with that process in real time. For example, skin temperature. If I asked you to change your skin temperature, raise your skin temperature, you wouldn't particularly be able to do it. But if I put a sensor on your skin that measured 1/10 of a degree changes, and then just do normal flux and variation, every time it went up 1/10 of a degree, you'd see the result. The green bar would go up on a monitor. And every time it went down 1/10 of a degree, let's say a green bar would go down. And because you're getting that information, that feedback, if I ask you to keep raising the green bar, most people are able to do it. Not sure how they do it, but by getting out of the way, the brain figures it out. And the green bar can go up, and you can raise your skin temperature that way. And why would we bother learning how to raise our skin temperature? I mean, it might be a fun trick to use at a cocktail party or something. But the reason is it elicits a parasympathetic relaxation response. And that essentially is what 95% of biofeedback is for, is to teach relaxation. And it can be very effective that way. The idea is that you learn to relax during a session, then you get used to the feeling of relaxation. And the idea is then to be able to generalize it outside of the session. Some people are not able to learn it. Some people are able to learn it, but not able to adequately generalize with it. And it's one of many forms, many modalities to teach relaxation. So even though it's good, it's still just one of many. And again, it's been around since the 60s. There's all sorts of studies showing how helpful it is in hypertension and various other chronic diseases. And that's biofeedback. So neurofeedback is the same idea, except the medium, instead of it being skin temperature, is brain waves. Brainwave amplitude, brainwave frequency, how fast it is, how slow it is. And similar to skin temperature, we put sensors on the scalp. And let's say we're just looking at frequency. If brainwave frequency goes faster, let's say a green bar goes up, and when it gets slower, the green bar goes down. So if we want someone to raise the frequency of their brain waves, we ask them to keep raising the green bar. The person doesn't know how they do it, but most people can generally learn how to do it. And we're training the brain to function at a higher brain frequency. So it's the same principle, just now we're using brain waves instead of instead of skin temperature or muscle tension or various other forms to use with biofeedback. So while biofeedback goes back to the 60s, neurofeedback has its own little history. And it started also in the 60s when Joe Kamiya was able to train various people to maintain certain brainwave frequencies. And so that was the first time anybody had seen anything like that. So that was interesting. That was in the early 60s. And then in 1967, there was a researcher named Sternberg. And what he did, he wanted to see if he could train cats to maintain a certain brainwave frequency. And so using operant conditioning, he was able to do that. And okay, nobody had seen that before, and that was interesting. And a few months after that, he got a grant to study a rocket fuel that was quite toxic, and it could cause seizures. So as part of his research, he exposed a bunch of cats, a whole group of cats, to this toxic fuel. And about 80% of them, within a few hours, had seizures and died. And about 20% of the cats either had seizures later or not at all. And they discovered afterwards, when looking at their data, that all the cats that didn't have seizures were cats from the previous experiment that had been trained. So somehow that training had stabilized their brains, so it had raised their seizure focus. So it was clear right then that something important physiologically was going on. And so neurofeedback then started, there gained interest in it. But then what happened is people were making claims for it. They were kind of overstepping what they could prove and making claims for it. And also, it was the early 70s, late 60s, and so there were claims made about alpha waves and meditation and things like that. And then they found out that you can generate alpha waves just by closing your eyes, and people looked kind of silly after that. At any rate, for a variety of reasons, it kind of went underground, and people in academia didn't really want to study neurofeedback. And it went underground except for a handful of researchers. And then in the 80s and 90s, it started making a significant comeback, and it's certainly gaining as we go on right now. There's probably, I don't know, at least 100 or 200, probably more studies. There's a complete bibliography of all the research on neurofeedback on the website of ISNR, and I'll get you that reference later. And it's broken down per disease. Most of the research has been various forms of clinical case series. There have been some double-blind studies, and more on ADD than anything else. And they're bearing fruit, and they're showing efficacy. And as we all know, it's starting to gain in popularity. So that's neurofeedback. There's various forms of neurofeedback. Most of them work using operant conditioning, and but not all of them. Some are more open-ended. And HPN is considered a form of neurofeedback, though it operates quite differently than the other forms. And in a nutshell, though I think all of you know, we have some sensors on the scalp, and it measures brainwave frequencies. And then it sends an extremely tiny signal back to the brain. That signal changes as the dominant frequency in the brainwave changes. So it's not a preset frequency. It's specific to you at that site in that very instant. And one way we understand what that signal is doing is causing a slight fluctuation in brainwave patterns and allowing the brain to get out of frozen stuck patterns. It's allowing the brain to reorganize itself. So it's not training the brain, it's the exact opposite. It's untraining or disentraining the brain, but disentraining it where it's stuck. So it's sending back pulsed waves that are out of phase with the dominant frequency. And there's various ways we manipulate those waves. That's fundamentally how it works. We don't consider it stimulation because it's much too low. And we use it much more briefly than anyone uses stimulation. We actually look at it as a disruptor, not a stimulator, a disruptor. That somehow this tiny signal interferes in a subtle way and allows these changes to happen. We think it works in part. One is because it is so low in frequency, so low in power, that it flies under the brain's radar. And also because the dominant frequency and thus the signal going back to the brain is constantly changing, the brain can't adapt to it. Because it brings up the natural question, well, if such a low power causes so much change so immediately, why don't devices with much higher power, like a cell phone, cause change in an acute way? Probably does cause changes chronically. But we think it's because it is higher power and the brain kind of hunkers down with it, but also it's a steady frequency, and so the brain can adapt to it, and the brain adapts very quickly. So the things that make it sound almost more implausible that it's such a low power and that it's constantly changing are actually the reasons it probably works, or are central to the reasons it works. Okay, let's talk just briefly about what HPN treats and what it doesn't treat. There's about 5 categories. So one is it treats affective disorders, emotional disorders, primarily depression and anxiety in all its forms. It treats monopolar depression, but also it can be very helpful in bipolar depression. It's not quite as reliably helpful in bipolar. That can be more difficult to treat because of the instability, the inherent cycling. So while I'm usually successful treating bipolar, sometimes I'm successful with the depression, but I can't hold because of the underlying cycling. So it's often used in conjunction with mood stabilizers. And it's also more challenging to keep track of where someone is in the cycle, or even if they are cycling at all. And I'll talk more about that later. So when I talk about anxiety, talking everything from mild chronic background anxiety to panic attacks to nightmares, all the way up to the extreme of post-traumatic stress disorder, PTSD. It helps in a variety of ways, but fundamentally by lowering the fight or flight response, the sympathetic nervous system, and enhancing the parasympathetic, the homeostatic part of the peripheral nervous system. So anxiety is part of so many other conditions, including learning disabilities, including autism, including OCD, that while we don't specifically treat autism, while we don't specifically treat or cure OCD, because anxiety is such a big component of it, we treat those things. We're very helpful with the symptoms of OCD and many learning disabilities. And it treats many cognitive problems. Probably the most common and salient example is ADD, ADHD. It helps with some learning disabilities, but not with others, and it's not easy to predict ahead of time. With ADD, it's reliably helpful, but not with all other learning disabilities. So there's a lot more experience that we need in those areas. A third category is what I call energetic. people with chronic fatigue, or chronic fatigue is part of fibromyalgia. As part of their improvement, we do see an increase in energy. And probably chronic fatigue and fibromyalgia are the result of chronic stress anyway, so it would make sense. So energetically, then traumatically, traumatic brain injury. Blunt trauma is the most common that we've treated. And it's surprisingly very, very effective for at least mild, moderate TBI, mild, moderate post-concussive syndrome. In fact, I've found it effective on pretty much everyone I've treated with post-concussive syndrome. And as some of you know, we're now doing a study treating former NFL football players. And so far, every single one has responded. We're up to 14, every single one. And then the last category I'll call outbursts. So of rage, for example, anger, sudden events like Tourette's syndrome, migraines, they're all very abrupt events. And seizures. So anything that's really abrupt like that. HPN will stabilize the nervous system and can be very helpful. Now some of these are much more difficult to treat than others. It's not as reliably helpful in Tourette's, for example, as we are with anxiety. The same with migraines. In seizures, I personally only have very limited experience treating seizures. People don't usually come in for seizures at this point. Some people have seizures, and but they're coming in for something else. I think it would become more common, but neurofeedback, there are clinical case series showing traditional neurofeedback helpful with seizures going back 30 years, and also just the experiment that Sternman did with the cats. So I think it will be used in the future a lot more in that particular area, and migraines also. I think I'm expecting it in actually all these areas to become standard treatment. So traumatic brain injury goes beyond blunt trauma or penetrating trauma. Let's say ruptured aneurysms, okay, is a form of brain trauma. A stroke is a form of brain trauma. And we can be very helpful in strokes, particularly when there's cognitive and speech deficits. Not as reliably so when there are motor deficits. You can't tell ahead of time. So in all those areas. So if you think about what I've just described, almost everyone either has or knows someone who has one of the above, which is extraordinary, the range that it treats. And we treat everything the same. We don't change the treatment based on diagnosis. I'll go into more later, but we modify treatment based on sensitivity and reactivity of the nervous system, and based on response to treatment. But diagnosis isn't really that relevant a factor. Neither is how long it's been there, surprisingly. So with treating TBI, it doesn't matter if it was 15 years ago or it was 1 year ago. And it also isn't necessarily a function of how severe it is. It's not more extreme PTSD isn't particularly more difficult to treat than milder version. What can be a factor is how genetic it is, how congenital it is, whether there's a long family history of it, etc. Now, we're still generally successful, but that's something we take into account in evaluating the patient. It's extremely successful. HPN is extremely effective at treating the symptoms of traumatic brain injury, of anxiety. 90% plus, I found. With depression, 85% plus. Except in cases of severe depression, when they haven't been affected even by ECT, electroconvulsive therapy. So I haven't found HPN effective in those conditions. With ADD, at least 80%. I have more limited experience with migraines, and I'd say I've only got maybe 60 to 70% right now. With anything that, besides migraines, that's abrupt, like anger, rage, impulse control, works very, very well. And not only does it work well, that the large majority of time, you can begin seeing changes the very first session. Certainly within the first few sessions, you're going to see a change. And the other thing that's really remarkable about this is that once treatment is complete, the brain maintains the improvements. It's much easier for the brain to work smoothly and effectively than to compensate for dysfunctional brain. It's easier to treat a condition when there was a period prior to having the condition where the brain was healthy. For example, in depression, most people weren't depressed their whole life. Most people aren't anxious from the get-go. So it's just getting the brain back to where it was rather than forging a brand new pathway. It's why treating traumatic brain injury can be so effective and rewarding, because the brain was healthy before it. Now, in forging new pathways, like many with ADD, it's actually more work for the brain. It's easier to treat post-traumatic stress disorder than ADD. It's actually easier to treat moderate traumatic brain injury than ADD. So it takes more sessions. With the symptoms of most of the disorders mentioned, I find it usually takes around 15 to 20 sessions. With ADD, it's often 30 sessions and more. And that's also true with some severe strokes. Autism generally requires a long-term commitment to treatment. What I personally do when it's with some of my patients who have autistic children is I treat them for a while and then train the parents to do it at home, and they buy a system, and it becomes more cost effective, and they can treat more efficiently that way. So if you're going to be treating a lot of children with autism, that should be one of your options. Not every parent can do that, and you still oversee treatment. But that's one way to be able to treat more people. The only other modality I integrate it with is an infrared light, which I'm going to go over tomorrow and how we use it. And I find that very, very helpful adjunct in treating and using HPN, particularly for those extremely sensitive people. But there's a variety of ways to use it. It can be helpful with traumatic brain injury. It's helpful with anxiety. When I started with this modality, I decided I personally wanted to see the limit of what it could do. So I made a decision not to use other modalities, and it would force me to just really push this one. And then I find that I don't find I need that much more. And most people do combine it. But most people don't really find how to be most effective with it either because of it, I find. So it's what you want to do. I would suggest seeing how far you can push it alone, and then once you have a good sense of that, then start adding more modalities. I haven't had good success with dementia. The second, very limited success with Parkinson's. Though with a few, I've been helpful symptomatically. One patient with Parkinson's I treated, his tremor was significantly reduced. He had less psychomotor retardation, didn't walk so slowly. He had some chronic pain that disappeared also, and the depression improved. He was significantly happier. It would last about 7 to 10 days, and so it would have to come back, but it for him made quite a big difference in his quality of life. We don't think it slowed the progression at all, but it helped symptomatically. It's questionable whether or not it helps with multiple sclerosis. I haven't personally treated it. I've heard some reports, isolated reports, but it's so hard to tell with multiple sclerosis because it's such a waxing and waning disease anyway. It's one of the hardest diseases because of that to tell whether a modality or medication is helpful. The demyelinating diseases, I don't think it helps at all. Like MS, like multiple sclerosis, the myelin is the white matter around the sheets. In the brain there's gray matter, the white matter. So there's a whole group of diseases, neurodegenerative diseases called demyelinating diseases. If there's an anxiety component to it, it'll help. If there's an eruption quality to it, it will help. It's important to realize when someone asks, does it treat? It's the question to come back, does it treat a specific diagnosis? Like even, will it help with my diet? And the question really isn't, will it help diets? It's if there's anxiety or depression that's contributing to your weight gain, then it can help. So not just the end diagnosis. And it'll be incumbent upon you when people ask you questions you ask them back to see if you can help, not just the specific diagnosis. It doesn't seem to really help with borderline personality disorder. It does help in the sense that they're often emotionally very reactive, erupt easily, have very little emotional resilience, so it helps with that. But there's still characterological qualities that this doesn't seem to impact. With schizophrenia, I haven't treated anyone, isolated reports that by reducing agitation, anxiety, there can be less paranoid ideation. And so it can be helpful. So it doesn't treat schizophrenia, but it can be very helpful because of that. All right, now let's move on. I've given some background and context, what it treats, what it doesn't treat, how it evolved. Actually, there is one part. Let me give a little bit more of the history because I want to talk about it in terms of lens. How did this come about? This really came about in the early 90s, where there was a researcher, a clinician named Len Oakes, who developed an entrainment device. A device where it was goggles, where you get feedback from lights flashing and also sounds based on what brain waves were doing. And he set up a particular system, and he found that some people were getting well in a pretty dramatic way, but a substantial number of people were getting overstimulated from this. So first they got rid of the sound, and the same thing, nothing really changed. So they started covering over the lights also. And it's still basically the same. Fewer were overstimulated, but a significant minority were. And there was just pretty dramatic improvement in a significant number. So finally, they covered it up completely with cardboard, so you can't even see anything through it. And the same thing happened. Then they got rid of the goggles altogether. And less overstimulation, but still really dramatic improvements. And didn't understand why at all. And they were lucky enough to get a grant, and they brought the system to Lawrence Livermore Laboratory. And engineers looked at it, and they were stumped at first. But then they figured out that the wires that were going from the sensor, were coming from the sensor, were not just bringing back information one way, but it was sending a tiny trickle of electromagnetic signal energy the other way. So 2 of the 3 engineers said, it's too trivial to affect biologic tissue. And the third said, who knows? And so it evolved from the who knows part. And the name went through several variations, and its current name is LENS, which stands for Low Energy Neurofeedback System. And HPN evolved from that. There's an electrical engineer named Corey Snook who worked with Len Oakes for a while on LENS, trying to figure out more what was going on. And then Corey made his own modifications and has taken it in another direction, which we'll talk about tomorrow. And that's where HPN comes from. Corey got interested as an electrical engineer in the whole field because he has a daughter with pretty intractable seizures, and was looking everywhere, and has been and continues to look everywhere for anything that'll help. So that's how he got involved in neurofeedback. Then he found that LENS was more effective than the other forms of neurofeedback, and the HPN more effective for his daughter than LENS. But that's the basic history evolution of HPN. It works on the same fundamental principle of sending a signal back based on the dominant frequency, and so they're similar. There are various advantages to HPN, and that's part of what I'll go over tomorrow. Okay, so someone has come to you for help, and you figured out that there's probably something that you can do that will help them. So now they're in your office, and you have to do an assessment. Okay, so the single most important quality or characteristic to be addressed in assessing a person is how sensitive or reactive their nervous system is. And I'm distinguishing between sensitivity and reactivity, because you can be very sensitive but not that reactive. You can be very sensitive and discerning and tell minor variations in smell, for example, like in perfumes. So that's someone who's sensitive. But the reactive is if they get headaches from it. So someone who's sensitive to light, similarly, they classically might have to wear sunglasses whenever they go out. So sensitivity and reactivity to the environment, not really talking about emotional sensitivity and reactivity, though they can overlap. So these are the basic areas to ask, are the senses, so smell. And the question I typically ask is, do you get a headache around perfumes and other smells? These are the people who put signs out, please don't wear perfume. They're very sensitive. Sound, some people are very sensitive, and to certain kinds of sounds, like clattering of dishes is a common one, though sensitivity to sound overall is less common than smell and sight, light. So 2 other qualities to asking about sensitivity and reactivity are, 1, someone who's really sensitive will typically be sensitive to medication also, and only be able to take small amounts. And also someone who's sensitive to just there being a lot of stimulation. So what I typically ask is, if you're in a mall during busy season, do you feel like you're going to be overwhelmed? It's not, do you like being at a mall, or it's, do you feel you're going to be overwhelmed and you have to get out of there? There are other things like low pain threshold, but I find with what I've gone over, it really covers it adequately. You can ask all sorts of questions, are you sensitive to weather changes? Or are you sensitive to, but I find what I've asked there screens it adequately. For our purposes, they're either sensitive or they're not. Okay, you treat them as sensitive even if they're only sensitive in one category. And it just means that you start at a lower amount. So it's easy to misjudge. So if there's any suggestion that they're sensitive, you just start lower. And then a third quality that we look at is what we call hardiness. How resilient they are, how well a person would tolerate it if they get overstimulated. Some people will get a headache and be in bed for 3 days. Others will get a headache and just, pop 2 aspirin, if that, and just keep going. And some people are hardy just by dint of what profession they're in, because they had to muster through. So soldiers, lawyers, doctors, most PhD students. And it's easy, because I've done it, be careful about confusing hardiness with reactivity. Because I've had, and I have it now with some of these, NFL football players. They're all extremely hardy, but some of them are also very sensitive. The sensitive is really your genetics. And at times in the beginning when in my early days of doing this, sometimes I mistook hardiness and thought, that they can tolerate this much or that much, and I was wrong. So hardiness has to do with how much they'll tolerate if you overstimulate them. It's not a factor in how much you give them. Just always specifically ask whether they had concussion or traumatic brain injury. Because I would like to do a whole separate talk on TBI. Maybe we will tomorrow. But there's such a wide range of symptoms that you normally don't think of. Yeah, I'm going to have to at least that you'll miss it. And often people won't remember if they did. Did you fall out of a tree as a kid, riding bike, other things? I ask about that. I always ask about migraines and seizures also. The only two where diagnosis does play a role, and only to the extent that I start very, very low with them, because you can cause a migraine, and I've done that. Then you also want to know family history to see if there's how genetic or congenital it is. Again, it doesn't necessarily make it a problem, but it's just good to be aware of. You also want to know the complete list of medications they're on, and including supplements. The reason I'm including supplements also is I've had patients who've just stopped magnesium, or one seemingly benign thing, even something that they didn't think was helping them. And it can cause pretty significant negative side effects, and it can confuse the clinical picture, what's coming from the treatment. And so one thing we'll go over, but when someone's having an untoward reaction, you don't understand why, is to ask, have they changed anything, their supplements? Another reason it's really important to know their medication, and it's important to emphasize this right from the very first session and afterwards also, is to not go off your medication. I don't even talk to someone about considering getting off medication until we've optimized where they are with treatment, so towards the end of the treatment. And again, if you're not an MD, you're not the one who changes medication. So you always do it in conjunction. Let me re-emphasize that. You don't change the medication. Now, you also have to be aware that the dose that they're on may become too much as they improve. So that's something to be aware of, and you'd want to let them talk to their clinician about. Too many times I've said this to patients, and they're feeling so good they forget I've said it and just take themselves off and don't even bother telling me. It bears repeating several times during the course, because it happens quite commonly. And then you want to know if their doctor has changed their medication level, because it's important in light of what's happening. Now, you prefer to change just one variable at a time, so you know better what's happening. If you change your medication, someone goes on a new antidepressant just when you're starting, it becomes harder to tell. Not necessarily impossible, because it'll have a certain pattern. You know, if they get better the day they have treatment, and then for a few days afterwards, and then it goes down, you know it's from this. So the other may be helping. And it usually takes longer for an antidepressant. It also is very helpful with withdrawal medication of any kind. And I'm going to go over this in detail tomorrow.
Including narcotics?
Including narcotics. And including using it with acute withdrawal, too. With anything, with alcohol. Okay, so you need medication history. And the next thing that you need are key symptoms that you're going to follow. So anxiety, insomnia, depression, outbursts of anger, whatever. At least 3 or 4. It's more important to have those symptoms from the point of view of being an HPN practitioner than it is to have a deep understanding of what's going on psychodynamically. Because you need something to follow. Usually they improve together, though not necessarily at the same rate. But sometimes you'll get improvement in one and some deterioration in another. And then you have to decide how you want to proceed. So those are the main features of history and what you need to know. So it's far less than the kind of history you need to take. So you see whatever context are you seeing someone just specifically for this, like maybe for ADD, and they don't need any other kind of support. Okay, so we've done an assessment, and basically what you've decided, what symptoms you're going to track, you've figured out what medicines they're on, supplements, you have their basic history, you found out if they have a history of concussion, and you've checked for migraines and seizures, and you've got a sense of whether they're sensitive or not. You treat them as, even if they're just mildly sensitive, you regard it as sensitive. And so based on that, based on sensitivity, you'll pick the protocol. We'll go over this when we actually work on the machines. So, but we'll pick, and we'll start to treat. The signs of overstimulation: it's tired, wired, spacey, and headache.